Hi, my name's Leanne Barron. Welcome to today's talk webinar on GLP-1 agonists and their impact on perianesthesia care. I'll be your moderator today. I have an Australian accent. If anyone has trouble, let me know. I'm a certified post-anesthesia nurse with experience in both the PACU and critical care settings, and I'm passionate about advancing nursing knowledge to improve patient outcomes. I've been in the nursing field for almost 40 years, so I've seen a lot of changes, and I've seen it, I'm pretty sure most of you have, and you know that if we can help increase our knowledge, it's just for the benefit of the patients. So thanks for all coming today. I think the patients will get a benefit from this. Before we begin, I'd like to go over a few housekeeping details. We'll spend the next hour together following that agenda that you have. And then the session is meant to be interactive. So we'll use the chat feature. I'm not sure if you can all see it, but if you go down the bottom of the screen, you should see a Q&A section as well as a chat. Please use the chat to say hello to your fellow attendees and tell us how long you've been in the perianesthesia care. The question and answer function button at the bottom can be used to submit questions at any time, and I'll do my best to see them and try and get them addressed during the meeting. Otherwise, we'll talk about that at the end. Now, in order to earn contact hours, you must attend the full session and complete the post-course survey within 5 days. And at the end of the webinar, we'll put up a Q&A code. Go ahead and just click on that, and that'll take you directly to the survey. Now, let's move on to the topic. Today, we are very happy to have Diana Isaacs. Let's just do those disclosures, sorry. Diana is an endocrinology clinical pharmacy specialist at the Cleveland Clinic. Diana is a leader in diabetes care, technology and education, and her work with the American Diabetes Association and American Association of Clinical Endocrinology has helped shape current best practices. We're thrilled to have her here today to guide us through this important discussion. Welcome, Diana.
Great. Thank you so much for having me. All right. Well, I guess I will go ahead and dive right in. Hopefully I can get access to advance the slides. There we go. So I'm really excited to be here. Thank you so much for having me. I work on the outpatient side, and I do have a scope of practice where I am prescribing medications and ordering labs. And so I'm often on the end where patients are saying, well, we have this upcoming surgery. What should we do with our GLP-1 agonist? So I think this is a really important topic. The objectives that I'm hoping to get through today are to describe the effects of GLP-1 medications on anesthesia and postoperative outcomes, to discuss strategies for managing glycemia during the perioperative period in people taking GLP-1 medications, and then to create treatment plans to address GI side effects such as the delayed gastric emptying with use of these medications. So let's go ahead and dive right in. And we will do that with, hopefully I can move along this slide. Let's see. I might need some help. All right, there we go. Okay, so I like to start off with, why is this such an important issue? As we know, a lot of people are taking these medications, and why is that? Well, one of their primary uses for these medications is for type 2 diabetes as well as for obesity. And we are seeing that the rates of both of these conditions are climbing very, very much. So the estimated statistics are that 38.4 million people in the United States have diabetes. That's 11.6% of the population. It's actually over 14% of the population of adults that has type 2 diabetes. And then 40% of people live with obesity. So this is certainly affecting a large part of our population. I might need some help advancing the slides because it just doesn't seem like it is working. Okay. So that brings us kind of to this rise of GLP-1 agonists. So these drugs, even though a lot of people think, oh, they're brand new, what's going to be, what are the potential harms of them? They've actually been around now for 20 years. The first available one was exenatide, that was available in 2005. And then now we have more potent ones that are dosed weekly. And specifically, you hear a lot about semaglutide, which is Wegovy or Ozempic, and tirzepatide, which is Mounjaro and Zepbound. And so semaglutide became available in 2017, and then tirzepatide in 2022. And of course, we have a lot of Hollywood celebrities using these agents, often for weight management. And the latest statistics show that 12%, which is 1 in 8 adults, say they've actually taken a GLP-1 agonist. So yeah, we'll advance to the next slide. So that brings us now to our first polling question. So GLP-1 medications are approved for all of the following conditions, except, and your choices are obesity, type 2 diabetes, sleep apnea, alcohol use disorder, and kidney disease. And it looks like the polls are hopefully working. So go ahead and pick which one you think. We'll see how familiar you all are with these meds. And then I don't know if there's anything I'm supposed to do on my end to end the poll.
No, but hopefully someone can actually see the results of the poll, Diana.
All right, well, I guess we'll see if I'm able to advance.
Kind of gets your brain thinking, though.
I'm seeing some people putting in the chat. See.
Gotcha.
All right, so I'm trying to advance the slide because I believe on the next slide is the answer. Um,
Yep.
So yeah, the correct answer is actually alcohol use disorder. And don't worry, I'll go through what these different indications are. But of course, we know obesity, type 2 diabetes management, it's been approved. But more recently, actually, tirzepatide gained approval for sleep apnea, and semaglutide gained approval for kidney disease. And so the one that it doesn't have an indication for is actually alcohol use disorder. So in the guidelines, these are prominently in there that they are the most effective for weight management. We've never had another class of medication that's been as effective. When it comes to managing type 2 diabetes, the American Diabetes Association standards of care, these are prominently in there for patients that have cardiovascular disease or patients that need the most potent glucose lowering and weight management. And then they're also first line for those that have kidney disease and type 2 diabetes. And then also now with sleep apnea, they are also indicated for those with obesity and sleep apnea. All right, sorry, I am trying my best to advance the slides, but maybe I'll try the keyboard and see if that works better. All right, so how do these drugs work? Well, for diabetes, we've known kind of how they've worked for a while in terms of their actions on the pancreas and in their GI tract. So GLP-1 is released in response to food, and this is something that helps to suppress the appetite within the brain. So helping a person to feel more full. It also slows gastric emptying in the stomach, which we'll be coming back to. And then within the pancreas, it actually stimulates insulin secretion and it suppresses glucagon secretion, but it does so in a glucose dependent way, meaning these drugs are not expected to cause hypoglycemia, and they're very effective at lowering glucose as well as lowering, decreasing weight. But there are some additional effects as well. So these are some of the other proposed mechanisms. Because why is it that there's such beneficial impacts on cardiovascular disease as well as in terms of kidney disease, right? So there are GLP receptors in other areas of the body. And so these are some of the additional mechanisms that are included as well. Like, for example, increased glucose uptake within the heart, actually affecting some of the taste sensitivity on the tongue. A lot of people will say, well, these really quiet all of that food noise, and it makes it so much easier to make healthy choices. And there are several benefits. So this comes from an excellent review paper from Daniel Drucker, who is just incredible with all of his research with GLP-1 medications. But we have a lot of evidence-based medicine, certainly for type 2 diabetes, for cardiorenal disorders, and for obesity. We've really established this with several agents. When it comes to other established benefits, there's likely benefits also for people that have experienced strokes, heart attacks, that have diabetic kidney disease. And then there's a number of indications being investigated. So for those of you that picked substance use disorder with that first question, you're not entirely wrong in that it's certainly being looked at for those indications. Also, some people report it helps to reduce other uh, behaviors that could become addictive, such as things like gambling or tobacco use. So those are areas of study. Those haven't been proven necessarily at this time, but they're being studied. And also even other areas like Alzheimer's disease and Parkinson's disease. So it's certainly very exciting, the potential of these drugs. And so I would say you're only going to see increased use, not decreased use. Uh-oh, we seem to have gone the wrong direction. I don't know if it's possible for me to just share my screen. I'm wondering if that might be easier, because it seems like we're having some challenges with these slides. Yeah, sorry everyone. If whoever is controlling the screen, if it's possible for me, that would be amazing. Great. I can go ahead and share my screen now, and all right, we'll put this into slideshow from, and then just tell me, do you see the slides or do you see the notes part?
We see the slides. We got the slides.
Excellent. All right. Thank you so much. All right. Hopefully we'll go a little smoother now. Thanks for bearing with me, everybody. So there's a number of GLP-1 medications. I've listed them out here. What I want you to focus in on is the half-life and the dosing frequency. Are they weekly? Are they daily? Because that's going to come into play as we talk about what some of these recommendations are. So you'll see that there's several that have long half-lives that are 5 days, like dulaglutide or Trulicity, or weekly, like exenatide, Bydureon, and semaglutide, and tirzepatide. Now, when it comes to indications, there are several. They're actually all indicated for type 2 diabetes. That was the kind of the original indication, and then they've expanded to these additional indications. So semaglutide, liraglutide, and tirzepatide all have indications for obesity as well. You will notice that, look, there's several that are actually approved in kids, 10 and over or 12 and over, with semaglutide for obesity. And I think that's important too, because kids need surgery sometimes also, right? So a kid also could be on these medications. And then several of them have specific cardiovascular indications. I've listed them out. For dulaglutide, it's people with diabetes and cardiovascular disease. For semaglutide, it's people with diabetes or obesity and cardiovascular disease. And then liraglutide is people with diabetes and cardiovascular disease. And then also on here under the other, semaglutide has an indication for kidney disease with diabetes, and then tirzepatide has sleep apnea with obesity.
Diana, let me jump in here. We are seeing the notes. So if you
Oh,
can
you
put it
are.
full
Okay.
screen, thank you.
Yes, I can switch that. So thank you. It's just, yeah, I just have to swap the perfect. I so appreciate that. Thank you. I don't have notes on there, but it makes you pick one. All right, awesome. So what about the safety profile of these drugs, right? So that's what everyone kind of is on everyone's mind. So this again comes from Daniel Drucker's paper, his review paper about, okay, what are the known adverse effects? And that's what's in the gray. And so we know that there are GI side effects like nausea, potentially vomiting, also diarrhea or constipation, and sometimes both, kind of on and off. Reduced bowel motility. So there can be ileus, which is certainly very relevant. Retained gastric contents or aspiration. And that's what we're really concerned about when it comes to surgery. There also can be other concerns like acute kidney injury, which especially with dehydration can occur, as well as gallbladder disease. Now, there's some other ones that are not quite as known, like sarcopenia. When there's a lot of muscle loss, that can occur. And then there's warnings about medullary thyroid carcinoma. There's been increased cases of pancreatitis. But as Daniel Drucker says, those are probably doubtfully really related directly to the medication. All right. Well, why is there this risk of aspiration then with GLP-1 agonists? Well, we know that retained gastric contents can lead to regurgitation, which is what can lead to these aspiration events. And why we care so much about this is because aspiration has high morbidity and mortality related to that. And this can include respiratory failure, multiple organ failure, lengthened and unexpected hospital stays, and even death. And there's a higher rates of emergency surgery and in people with obesity and diabetes to begin with. And then you throw in a medication that can further increase this, and that is cause for concern. Additionally, statistics show that up to 30 to 50% of people with diabetes have some form of delayed gastric emptying, even if they're not taking a GLP-1 agonist. And the long-acting GLP-1s, the ones with the long half-lives, can actually potentially delay gastric emptying for up to 8 weeks until you're waiting for it to completely be washed out of the system. And what I do want to make sure I emphasize, though, is that with ongoing use of GLP-1s, this delayed gastric emptying actually often is not a continued mechanism. It is something that typically occurs with a new starting the drug or with a dose increase, but actually continued GLP-1 use can actually even lead to tachyphylaxis. So this is more of a concern with someone who's experiencing GI side effects or who has recently escalated their dose. And I think that's going to be an important thing to keep in mind as we go on in this presentation. All right, so what about this regurgitation, this gastric emptying, aspiration? Where did this all come from? Because these drugs have been around for 20 years. Well, case reports started getting published and coming in. And so here's one that was published that says there was a 48-year-old female that was having a breast lumpectomy. And they found that there was actually regurgitation of a large volume of gastric contents upon induction of anesthesia, despite the fact that there was a long preoperative fasting period of 20 hours for solids and 8 hours for liquids. Now, this person was taking semaglutide 0.5 milligrams weekly for weight loss, and the last dose was 2 days prior. So there was no dose being held. Her BMI was 28, so she had kind of successfully lost some weight already. And she had no other risk factors, not even obesity. So no risk factors for that. So the authors, based on this, kind of made their own conclusion, like, wow, this is a major risk factor. We should get it out of the system, and it should be held for 4 to 5 weeks prior to planned surgery. Well, that brings up the question. So yes, you could say the safest thing is just let's hold the GLP-1. Since there is this potential risk, let's just wash it out of the system, make sure it's out 5 half-lives, so at least 5 weeks, and we'll have everyone do that. Well, the problem is Certainly people taking it for diabetes, if you stop taking it, they're going to have elevated glucose levels. And many people with obesity also have prediabetes, and they also could have elevated glucose levels if you just stop this medication. And that can lead to things like impaired wound healing, increased risk of surgical site infections, which can lead to increased hospital stays. It could also even lead to delays in surgery if someone's experiencing a lot of hyperglycemia because it was stopped. And also, there are studies that show that even holding it for 3 weeks or more showed residual gastric contents. So that may not be the answer. All right, so this brings me to my next polling question. And I guess because of the fact that I'm now sharing my slides, we might have to do this as like a chat queue. Oh no, it's coming up. How cool is that? All right, so the question we have now is, if a person who takes a 1 milligram weekly dose of semaglutide stops for 1 week, their plasma concentration will be similar to someone who's taking 0.5 milligrams weekly and has not stopped. And so it's a true or false question. And we'll see what you all think. I'll give you a few seconds to think on that. And it's okay if you don't know, just guess, and then we'll talk about it. All right, I'm going to see what happens when I press the next key. All right, I don't know if it showed how many people got it right, but the correct answer is that it is actually true. And the reason I wanted to, give this question and talk about this is because this creates another clinical conundrum, right? Do you do the same thing for someone that's on 2.4 milligrams of semaglutide versus someone that's on 0.5? Because if they're all holding the dose the same amount of time, the person on the higher dose is going to have still more in their system. And is that going to affect surgical outcomes? So that's kind of just another layer in the complexities of all of this. So more case reports started coming in. Here's another example: a 42-year-old male that had Barrett's esophagus and underwent an upper GI endoscopy. And, it was his 5th procedure in 2 years. He had no issues with any of the others, but he started semaglutide 8 weeks prior to this one. And he was doing an 18-hour fast. And upon the introduction of the endoscope, there were large quantities of liquid and solid material encountered in the stomach. So the authors of this case report concluded, we should be using point of care ultrasound to assess gastric content in GLP-1 users so we know what we're going to expect. All right, well then our societies start getting in because they're like, we need to come out with some guidance because these case reports are floating in. And so the American Society of Anesthesiologists consensus-based guidance on perioperative management of patients on GLP-1 receptor agonists. This came out in June of 2023. And what they said is that for patients on daily dosing, consider holding it on the day of the procedure. For patients on weekly dosing, consider holding it a week before the procedure. And you should do this irrespective of the indication, whether it's weight loss, type 2 diabetes, the dose, the type of procedure. And if GLP-1 agonists are prescribed for diabetes management and are held longer, then you should bring in endocrinology to figure out kind of what to do with the diabetes therapy. Well, not surprisingly, people came in and were like, well, wait, what do we do this? Why are you saying it doesn't matter the dose, the indication? And so here you have other organizations kind of came out and said, we think of it differently. We think maybe we should hold 3 days before a procedure for a daily, or maybe we shouldn't hold it at all. And so this kind of led then to an FDA warning. And this warning came out in November of 2024. And it said, you know what? There is a risk of pulmonary aspiration during general anesthesia or deep sedation with these drugs. There have been post-marketing reports. Overall, they're rare. The available data is insufficient to inform recommendations. And so instruct patients to inform their healthcare providers and if they're taking a GLP-1, and ask their healthcare team what to do. So this really brings us to the problem of why we're here today. So what does the healthcare team actually supposed to tell their patients when the data is so mixed? So if you're very confused right now, don't worry. What I am going to do next is I am going to share the state of the evidence, and then I am going to go through the new updated multi-society recommendations so you understand where this is all coming from and kind of where we're going and maybe what we would want to advise our patients. So I'm going to go through this. I'm not going to spend a ton of time on the literature, but I really feel like you need to know what's out there to understand where these recommendations are coming from. So this was a scoping review of GLP-1 receptor agonists and basically asking the question, are they associated with increased gastric contents, regurgitation, and aspiration events? Because simply relying on a few case reports, all those patients could have had other comorbidities and other things affecting that. We really need more quality data. So this included 4 prospective, 6 retrospective, 5 case series, and 9 case reports. So 8 of the studies evaluated residual contents comparing GLP-1 users to non-users. And 7 of those studies reported a significant increase in residual gastric contents in GLP-1 users compared to non-users. So there was more gastric contents. 3 retrospective studies evaluated for aspiration events, finding that there was actually no significant difference in aspiration events. But one of the things the author notes is that there were a lot of confounders with these different studies, that patients had other risk factors for whether it was aspiration or residual gastric contents, that it makes it difficult to really make conclusions from that. So we have other reviews that occurred. This one is specific for cardiology. It was a perioperative use of GLP-1 receptors in patients undergoing cardiac procedures. And their rationale for this was that a lot of patients with obesity and type 2 diabetes are getting cardiology procedures, right? They have a higher risk of cardiovascular disease. And that there's really, we have to find the balance of continuing the GLP-1, which we know can delay gastric emptying, especially if someone recently escalated the use, but versus withholding, which can really cause more increase in glucose and other post-op complications. And they admit there's no consensus, that the consensus statements have really been varying anywhere from holding for 1 half-life to 3 half-lives. And so what they showed, there actually wasn't robust data specific to cardiac procedures. The 3 studies that they included were all prospective, which is going to be a higher quality than a retrospective where you're looking backwards. But they all used the drug liraglutide. It was a shorter term use, but interestingly, the liraglutide actually improved outcomes compared to patients that were just using insulin alone. And there were actually no higher rates of gastric regurgitation or aspiration. One study did have higher rates of nausea and vomiting compared to non-GLP-1 users, but overall, there was no difference in these adverse effects. All right, well, that's an older drug. Tell me about semaglutide, because that's a drug that people are much more commonly using now, right? So this study was the relationship between perioperative semaglutide use and residual gastric content. And this is a retrospective analysis of patients undergoing elective upper endoscopy. So it is a retrospective study, but it's difficult to do a prospective randomized controlled trial. So that's a lot of the data that we are relying on right now. So in this study, they found actually that semaglutide use, as well as if someone had preoperative digestive systems like nausea, vomiting, dyspepsia, that they were all associated with an increased residual gastric content. There was 1 case of pulmonary aspiration, and that did occur in the semaglutide group, which it's only 1 case, so it's difficult to come to conclusions with that. And interestingly, though, in this study, their way of practice was to hold the drug before the procedure. And so most were holding the drug for 10 to 14 days. And despite holding it for that time, there was still this increase in the residual gastric content. And that could be because even 14 days, the drug is still going to be in the system. All right. Well, here's another study, the risks of peri and postoperative complications with GLP-1 receptor agonists. And the aim of this study was to assess whether adults with diabetes undergoing general endotracheal anesthesia during 9 common surgical procedures, if they had increased risk of peri or post-procedural complications, again, comparing those that were using GLP-1s to those that were not. And this had a very robust sample size. This had over 13,000 adults. And in this, 16.5% of them were treated with GLP-1s, and then they were compared to those not. And the punchline is that there was actually no increased risk of peri or postoperative complications. And even, when they broke it down, what you're seeing at the top are aspiration events, which were low in both groups, 0.61% versus 0.4%. Respiratory failure, hypoglycemia, inpatient mortality, very, very similar. In fact, the group on GLP-1s actually had better outcomes when it came to antiemetic use and decelerated gastric emptying composite. So this fairly large study showed that there actually wasn't increased risk of these events. Again, this is retrospective based on looking through an electronic health record. It's not a prospective randomized controlled trial, but very interesting nonetheless. Now, here is another study. This was the effect of various perioperative semaglutide interruption intervals on residual gastric content assessed by esophagogastroduodenoscopy. This is a retrospective single center observational study, but the reason I wanted to include this one is because they actually they looked at, well, what happens when people hold the semaglutide for a week versus they hold it for 2 weeks versus they hold it for 3 weeks? And are there any differences to really inform what are we supposed to be doing? And so what they found was that there were 1,094 that were included, so 123 on semaglutide, the rest were not on it. There was an increase in residual gastric content compared to those that were not on semaglutide. It was 5.12% versus 3.19%. And then they divided it up. So some patients were on it, the 26% withheld it for less than 7, 46% were between 8 and 14, and then the rest were actually, 21% were between 15 and 21 days, and 6.5% were actually more than 21 days. So what happened with those? Were the ones that held it for more days, did they have better outcomes? Well, that is what is on this next slide. So this shows the different outcomes that occurred based on the number of days. And if you look at what you're seeing at the top is the summary of propensity weighted analysis. And basically the greater than 21 days had a lower odds ratio, meaning they were less likely to have these residual gastric contents when it was held for 21 days prior to the procedure. And so what the authors conclude is that, perioperative semaglutide use is associated with increased residual gastric contents in elective EGD patients. Preoperative semaglutide discontinuation for a minimum of 21 and 14 days in patients with and without ongoing GI symptoms resulted actually in similar residual gastric content as non-semaglutide users, meaning that patients really need to hold it for more than 3 weeks to lower that risk. That is what they found in this study. And that's very interesting because our current guidance is saying 1 week. But this study showed that 1 week may not really be enough to note that difference. Now, again, this is a retrospective study, so we can't say definitively that is true, but it adds to kind of this whole conundrum of what do we do? All right, don't worry. I'm getting through the data. We're getting there for those that are less into all the data. So I really wanted to include this one because this is a large study with 2 de-identified U.S. healthcare system databases looking at GLP-1 receptor agonists before upper GI endoscopy and the risk of pulmonary aspiration or discontinuation of the procedure. And this was even larger. And what's unique about this study is they actually compared both GLP-1 agonists and SGLT2 inhibitors. And SGLT2 inhibitors are another very common medication that we use with type 2 diabetes. And we certainly would not expect that there would be an increased aspiration risk with those drugs. And so what's nice about this is it's kind of serving like its own control group, because that's the challenge with a lot of these studies. There's not a control group. So it's like, how do you know for sure that there's an increased risk or not an increased risk. So this was over 24,000 adults using a GLP-1 receptor agonist. And you can see mean age was almost 60. And over 18,000 were using an SGLT2 inhibitor. And then the rest, over the 24 were using a GLP-1. So a lot of people in this study. So among the users of GLP-1 receptor agonists and the SGLT2 inhibitors, the weighted risk was 4.15 versus 4.26 for pulmonary aspiration. And what this means is there essentially was no difference. So the risk of pulmonary aspiration was basically the same. So it wasn't zero because patients have other risk factors for pulmonary aspiration, but it was very, very similar. Now, the discontinuation rates were different though. So it was almost 2 times higher in the GLP-1 group. So 9.79 versus 4.91. And so that certainly begs the question of why were these discontinuation rates higher? And the authors conclude that this could really indicate that there's a higher risk of retained gastric content, and there was concern about pulmonary aspiration, and perhaps that some of these procedures were simply stopped. And that is why you don't see higher aspiration rates, but it's because the team chose to stop it. And you kind of wonder, well, what would have happened if they didn't stop it? Now, they did go further and did a subgroup analysis to see, were there certainly any differences in terms of the drug used and other types of factors. And pretty much, there wasn't, huge differences in terms when it came to BMI and the type of anesthesia. We do see that tirzepatide and semaglutide seem to have higher rates of discontinuation compared to the others. That could be based on its longer half-life. It also could be because there were more patients taking those drugs, although tirzepatide did not have more taking it, but it could be, a reflection of that too, the numbers of people taking them. Okay. So that is my whirlwind overview of the literature. And I did, I was looking into this and doing literature searches and really trying to pull out the meat of what's out there so that we can understand the recommendations. Because unfortunately, like other conditions, the recommendations are not as clear cut. It's very much individualized, done through shared decision making, and also done, having health system create policies based on their unique patient populations. So I want you to be thinking through that lens as we now go into these multi-society recommendations. So one thing that I want to call out that is unique about this recommendation compared to the one that I showed in the beginning from 2023 is now we have more than one organization putting these together. There's actually several. There's the American Gastroenterological Association, the American Society for Metabolic and Bariatric Surgery, American Society of Anesthesiologists, also the International Society of Perioperative Care of Patients with Obesity, and the Society of American Gastrointestinal and Endoscopic Surgeons. So I think when you see all of these organizations coming together to put out guidance, that tells you, A, this is an important problem that needs to be addressed and people need to be on the same page. And then I think also we can really have confidence in these guidelines that multiple organizations are really endorsing these. So what are the actual recommendations? So this was actually, there's a great commentary in the guideline itself, and then there's this nice editorial associated with it that combines the 3 recommendations into this nice table. So recommendation 1 is standardized, are there standardized preoperative assessment for risk of delayed gastric emptying? And are there additional risk factors? The presence of GI symptoms suggesting delayed gastric emptying, recent dose increases or higher doses and weekly administered medications may increase the risk of GI symptoms. And so that takes us to back at the beginning when we talked about, if somebody has those GI symptoms, they're having nausea, vomiting, or they recently started the medication, or they recently increased their dose of the medication, those could all provide these additional risk factors for the delayed gastric emptying. And then just taking into consideration these additional medical conditions that could impact it. So if that's there, that is going to definitely guide what we're going to do. So the second part of this is that selective preoperative care plans based on delayed gastric emptying assessment and shared decision making. So you can continue the GLP-1 preoperatively if there's no concern for delayed gastric emptying. So meaning someone doesn't have these other conditions that might affect it. They don't have gastroparesis. They didn't recently start the medication. Then it may be safe in those situations to just go ahead and continue taking it, not holding the dose. But what if there is an increased risk? What if there is that elevated risk? Well, then we have some options. We could recommend a liquid-only diet for at least 24 hours prior to the procedure with the usual recommended fasting protocol to kind of reduce the risk of retained contents, or evaluating the feasibility of medication bridging with the GLP-1 needs to be discontinued. And that would be looking at discontinuing it for kind of up to, that could be up to a month or more if you want a weekly agent to be completely out of the system. And then recommendation 3 is that on the day of the procedure, reassess for delayed gastric emptying and mitigate the risk if there is clinical concern. So if there's no risk and there doesn't look like there's any delayed gastric emptying, great, the procedure can go on as planned. But if there's elevated risk, then you have a few different options that you could do. So you could consider point of care gastric ultrasound, which can be a great way to assess if there are gastric contents remaining. Although one thing to keep in mind is that feasibility of that. Is there always an ultrasound available? Is that going to fit into the workflow? Is that something that can always be done depending on the health system? The second one is, well, consider rapid sequence induction of general anesthesia if appropriate. So if there's not other risk factors that would limit the ability to do that, that can be an option. And C, they say, do whatever you can, really try to be proactive to minimize the potential procedure cancellation whenever possible by having a plan in place and kind of advising people what to do prior to the procedure or surgery, as well as kind of a game plan on what to do the day of. Then we can hopefully prevent cancellations of surgeries and also have the best outcomes from surgery as well. All right, so what are kind of some of the things that would increase someone's risk of aspiration? So we talked about the things related to the drug. And another thing I want to highlight for those that may be a little less familiar with these drugs. So our commonly used ones that we're seeing a lot of people on are semaglutide and tirzepatide. Well, tirzepatide has 6 doses. You generally start at 2.5. And then the next dose is 5, and then 7.5, then 10, 12.5, and then 15. So all that to say, it might sound like no big deal, like, oh, we just have to worry about the patients that, when they started it, if they started it in the last month or two. But that's not actually the case because there's 6 doses. And so it could be someone's been on it for a couple of years, but just recently they went up on their dose. So there are a lot of doses. Similar with semaglutide. With diabetes, there's a 0.25, 0.5, 1, and then 2. And then with obesity, there's a 1, and then 1.7, and then 2.4. So there are multiple doses that we have to be aware of. The other thing, though, is certainly other conditions that can affect gastric emptying, for example, Parkinson's disease or gastroparesis. And people with longstanding diabetes commonly have gastroparesis as well. So they go on to say a few additional things like, okay, when should you hold the GLP-1 agonist? And they do say, well, we really need to balance holding it with the risk of hyperglycemia. what I would say is if you're holding it for a week, generally that risk of hyperglycemia is pretty low with a weekly agent because most of it's still in the system, right? As you start to get beyond a week, then there can be more hyperglycemia, which is not ideal prior to surgery. And it might sound easy, like, oh, we'll just bridge them. We'll bridge them like we do with Coumadin. Well, that is resource intensive, and not everyone feels comfortable starting insulin if needed, adjusting the insulin. Like that actually is a lot of work. And if you don't have dedicated resources and someone can't get in for their appointment, that can lead to hyperglycemia or delayed surgeries. Another thing they point out is, well, hey, maybe a simple solution would be, well, people with diabetes will keep them on. And then the people with obesity, they don't really need it because, their glucose is fine. We'll just take them off of it. And they cautioned against that because that can really lead to this obesity, overweight bias. And plus, I would argue that people who've been on it for a while for their weight, we don't know what'll happen to their glucose when they stop the agent. They could see increases, and that may not be the safest thing either. And then they do say if you are going to hold it, just follow the original guidance that came out last year. Go ahead, do 1 day for daily formulations, 1 week for weekly formulations. I think what this is essentially saying is like we don't have evidence to say 1 week's better than 2 weeks versus 3 weeks, other than that one retrospective study. And that we want to be careful about having too much hyperglycemia. And my thought with this is that because if someone is having GI symptoms and you're holding it for a week, that may help to reduce those GI symptoms. And so I suspect that's kind of where that guidance is coming from. For dietary modifications, so 24-hour liquid diet, similar to a colonoscopy prep, has been proposed that can really help as well. Also, the use of the gastric ultrasound to assess the aspiration risk, and then rapid sequence induction of general anesthesia for tracheal intubation to minimize the aspiration risk versus procedural cancellation when possible. All right, so those are our multi-society guidelines. But I did just want to share, there's one other guideline that came out from this UK consensus. And this, they don't 100% agree with the Americans. But this also, I think, is an impressive multidisciplinary UK consensus that you can see a wide range of organizations really came together. And I think there are some good things in their guideline that are worth looking at and taking into account as well. So they say, shared decision making, individualization. We want to look at all of the different factors, right? What drugs, what medications is the person on? Are they on other meds? GLP-1s are not the only ones that affect gastric emptying, right? So what other risk factors does the person have? What are their other comorbidities that they're taking? How was their fast? Like, how long was it? The procedure, is it urgent, or is there more to time? That's an important consideration as well. And of course, we want to look at the different outcomes. Pulmonary aspiration is the life-threatening outcome that we're very concerned about, but we also care about other things like glycemic control, weight gain, and potential complications from rapid sequence intubation also can occur as well. So some of the things they say, obviously discuss these risks with the patient. They are actually on team, just keep using the GLP-1. And I think that really comes from the fact that the data is not strong. When you hold it for a week, it's not really clear that makes much of a difference, right? They recommend adhere to recommended fasting guidelines. They actually say that you may want to be cautious about relying on upper GI symptoms alone to determine gastric content. Yes, that's a risk factor, but there's certainly more that goes into it than just those symptoms. And they recommend regional anesthesia should be considered as the primary anesthesia technique, actually. And they are proponents of using point of care gastric ultrasound. So hopefully you can see there's not 100% clear guidance. This is an area where the literature is continuing to evolve. And what we really need is we need a good prospective randomized control trial to really probably determine what is going to be the best strategy. In the absence of that, I think following the existing guidance and coming up with a procedure, with a policy for your respective health system is going to be the way to go, understanding that it should be flexible as we gain new information. So I figured I'd go ahead and share what our policy is at the Cleveland Clinic. And I am in no way saying that this is the best policy. This was done a little bit through trial and error and based on the existing evidence that we have so far. So we do follow the guidance from the multi-society US organizations for holding the GLP-1 1 week prior to surgery, or 1 day if it's one of the daily ones like liraglutide. We actually assume full stomach if taking a GLP-1, even if it was held. And they're actually doing the usual fasting time. So they are not doing like a liquid diet for longer. On an individual basis, that could certainly be done, but that is not routinely done for everything. What they are doing is they are doing rapid sequence intubation. And what I've been told really by our surgical team is that they were, for a period of time, doing the point of care ultrasounds. And they did even try things like have people do extended liquid diets, and they found that it wasn't clear that that was really helping. There were still a lot of people that had residual gastric contents despite doing those things. And because it was so common that there were residual gastric contents, they didn't feel like the utility of always using the point of care ultrasound was worth it. And so for that reason, they've made the choice to go with a rapid sequence intubation for these patients. And certainly this can change as new evidence evolves. So with all of that, with that big data dump, I want to now bring it to home and go through a patient case. And let's talk about how would we approach this scenario. So we've got Jenna here, Jenna is 56 years old, female, and she's taking semaglutide 2.4 milligrams weekly for obesity. And she has surgery planned for a total knee replacement. Her A1C is 5.5%, so she does not have diabetes. Her blood pressure, 132/78, and her BMI is actually 29. So she has lost 35 pounds since starting the semaglutide. And she's actually been on this dose. She's on the highest dose, and she's been on it for 1 year. She denies having any side effects, and she's very happy, she was able to lose that 35 pounds. So the question is, here we've got our polling question. Well, what do you do with this patient? And our choices are that we could hold the semaglutide for 1 week prior to the surgery, right? We could have her hold it for 4 weeks prior to the surgery. We could have her continue the semaglutide, but say, let's go ahead and do a 24-hour liquid fast prior to the surgery. We could have her continue semaglutide with the usual fast, but do a gastric ultrasound just to double check, are there any residual gastric contents? And then E is we could continue semaglutide with the usual fast, but we're going to go ahead and do the rapid sequence intubation. So I'm curious what you guys pick. I don't even know if I can see your poll. So if you guys want to put in like the chat, the Q&A, I'm sure they'll be able to see your poll later. So definitely fill out the poll, but I'm just so curious what you guys all pick. Because I don't, I guess I'll give it away, but I don't think there's necessarily one answer. I think it could depend on a few different things, and perhaps there's additional information you'd want to know too. Yeah, I see someone put C, D, E. So someone's putting A and C. Someone put E, exclamation point. I love it. I love it. So, kind of thinking about, well, if we were following our Cleveland Clinic policy, right? We technically go ahead and with the Cleveland Clinic policy, we technically have them hold it a week before surgery, but we don't modify the fast and we do the rapid sequence intubation, right? So it's kind of a combination of A and E. But I don't think, I think you could also argue that, C, I don't think it'd be wrong if the patient if you explain to the patient, like, listen, you're on this medication, there is an increased risk of these residual gastric contents. And then we might have to do the anesthesia a different way. And that sometimes can be a little less comfortable. How would you feel about trying to do a 24-hour liquid fast? It might work, but there's a chance it might not, and you still might have residual gastric contents. So some patients might say, well, that's fine. Like, I don't mind doing liquid for a day. Maybe I'll lose more weight. So I think some of it is through shared decision making. I can see other patients might say, oh gosh, like I need to eat. I can't go into surgery without eating that long, without having solids. So I think some of it is going to be based on that. And then, additionally, if you have a gastric ultrasound and you can use that, if you're going to have her do the liquid fast, wouldn't it be great to verify if there are any residual gastric contents before you go in there? So truthfully, I think it can be kind of a combination of these different things. What I would definitely recommend is having a policy, because when you don't have a policy, then it's like, it can be chaos, right? You don't have a routine of what you're doing, and think that's when you can have more adverse situations. So we're going to continue on with this case, though. Now we still have Jenna, but now it's a different situation. She has nausea. She recently went from 1.7 to 2.4 milligrams and is experiencing nausea. And so the question is, well, how might that change your plan? Because we took someone that was probably pretty low risk and now may have that higher risk because she's escalating the dose and she is now experiencing symptoms. And so what I would say with this is something like a total knee replacement can be planned, right? This is not emergent surgery in most situations. So I think we can plan for this. And it would be important to provide that education to Jenna, because it probably, whoever's doing the surgery is not the one managing her semaglutide, right? That she has a discussion with her endocrinologist, with her primary care provider, and says, oh, I'm having this upcoming surgery. Like, what should we do with my semaglutide? And so I would say this would not be the time to go up on the dose. If anything, we should be staying at the same dose. We could even go down on the dose if she's having GI symptoms. But I think that conversation is really important. The problem is when there's not that communication and she just shows up and she's already at this higher dose that she just started a week ago, and that kind of can be more challenging of what to do, and having maybe perhaps a longer fast or reevaluating even the date of the surgery might be things that need to be done, or doing the rapid sequence intubation. And just further along, now I've changed it a little bit. So what if Jenna recently increased the dose and was experiencing GI symptoms and also had type 2 diabetes, and her other meds include insulin glargine and empagliflozin, and kind of how you might change your plan based on this. And so what I'm trying to go with this is that she's taking it for type 2 diabetes, right? So we know this is making an impact on her glucose levels. We'll assume her A1C is higher, right? She has diabetes at this point. And so because she's on insulin glargine and empagliflozin, we have the opportunity to make adjustments. Now, empagliflozin it's an SGLT2 inhibitor, and typically we also actually we hold that 3 days prior to surgery too. So we want to be mindful that if we do anything with those drugs, that we're going to have to probably do something with the insulin, and someone's going to need to help manage that. And CGM, continuous glucose monitoring, is a great tool for someone that's on insulin, because we would expect that we would need to adjust those doses. And we, of course, want to avoid hypoglycemia, but also hyperglycemia. All right. Well, with that overview, I want to make sure that we have time for questions. So just a few summary points I want to leave you with before we get into the Q&A. So GLP-1 agonists it appears they do increase residual gastric contents, which can increase aspiration risk, although fortunately the overall aspiration rates have been low. There are many proposed strategies to mitigate this risk, but I would argue that if all you do is hold a dose for a day or a week, that is probably unlikely to mitigate the risk. There's probably other strategies that need to be taken into account, like gastric ultrasound, liquid diet, and rapid sequence intubation. And then treatment plans should, of course, take into account all of the other patient-specific factors and resources that are available within the health system. And with that, I will now turn it back over to our wonderful moderator for Q&A.
Thanks, Diana. So thank you so much. That was really informative. There's a lot of great studies being done. Looks like it's a kind of a work in progress. You've given a lot of valuable insights into the mechanism of action, anesthesia considerations, perioperative challenges, etc. So now we've got a couple of great questions that we can ask in just a second, but while we wait for a couple more to come in, if anyone else has any good questions, if you want to put them in the Q&A, and we'll try and get to them now. One question that I did see, Diana, while we're waiting for everyone else to put one in, was a question from Megan Chris, I believe it was. She was asked, let me just see if I can find the question. Let's do Nola Bird first. I think, Nola, we answered that question for you with severe symptoms, GLP, how long for surgery, ideally. Nola, perhaps we could do that other question. Nola is asking about idiopathic intracranial hypertension usage with GLP. We can maybe ask that question to Diana direct, or Diana, do you want to try and have a stab at that?
Yeah, well, so we don't typically, I would say that's not, if anything, these drugs usually decrease blood pressure. The expected things we see are actually decreases in blood pressure, and then there's a minor increase in heart rate, usually by about 2 beats per minute, which is not generally thought to be clinically significant. So yeah, that'd be my response to how it impacts blood pressure and pulse.
Got you. There was another question. I can't read my own writing, Diana. That's the problem.
Yeah, I don't even see the Q&A thing anymore. It's like it disappeared.
There was a question in the chat that Kimberly Rose.
Oh, here it is, Q&A. Okay.
Got it?
Yeah, I see it now. Okay.
Yeah. So a couple of them, Megan Christ, who makes your decisions at the Cleveland Clinic? I'm guessing people are starting to think, well, maybe we should get on board and get local.
Yeah, I can do that because we have a hospital committee for diabetes, and it's interdisciplinary. And also we're a big system. So it's not just like our main hospital. We have all these like sister hospitals as well. I don't know why they call them sister and not brother hospitals, but anyway, so it's through this committee, and what this committee does is they take into account the literature, what the guidelines say, and also we talk with other big health systems too. I think it's great to collaborate and find out what policies are at other systems, and that can really help to inform your existing policy as well.
Thank you.
I want to address one. I saw one quickly. I finally figured out how to access the Q&A. But like the question about how can you trust if your patient is taking this medication? I think it's a really good, important question, because the reality is a lot of people are taking these medications and they're getting compounded versions. They may not show up in they're not going to be on their med list because they may not have talked to their provider about it. And so I think that's all the more reason to have an approach like anything can happen and be ready for anything. But I think trying to have that conversation, I think this is where open communication is really important, and not being judgmental, just simply really having someone meet with them before and say, like, listen, if you've taken these, I would say ever, there can be an increased risk. And just getting the person to feel comfortable to share that information is important, because I think in using the compounded versions, there's this added safety risk because we don't always really know the dosing and the formulation. And so we may need to use even extra caution in those situations.
Excellent. Got another one here from an anonymous attendee. How is delayed gastric emptying for clear liquids from the GLP agonists?
Oh, how is it? Why is it delayed?
I guess what they're saying is, with clear liquids, are they emptying that, or is it just as bad with the clear?
Yeah, so I don't think clear liquids is an issue. I think it's with solids that is really the issue, that it's just slowing that gastric emptying. With clear, I don't think that would have be expected to have an impact. I think the challenge is that even in cases where someone's done like 24 hours of clear liquids, sometimes that residual gastric emptying, it's slowed down so much that they still have contents that are in there. And that's really the challenge.
And I guess if there was an element of doubt, maybe they would go ahead and do that point of contact ultrasound, do you think? Or
right. So I
they're
think that's a
using
great
that?
option. If you don't know and there's uncertainty, doing that would be a great strategy because then you would know for sure what you're walking into.
Just going through these other questions. Thank you for all these questions. You guys are getting the most out of this lecture, and I understand that each place is going to have to develop its own protocols.
So I want to address the question. There it looks like there's
Mhm.
one about when GLP-1s are prescribed for obesity and the medication is stopped, kind of what would happen to those metabolic effects. So with at least if there's truly just it's obesity there, you don't have to worry about the diabetes, then I think the risk is less. I think the challenge is, let's say someone's on the highest dose and you decide you want to wash it out of the system, you're going to do like a month without it. So they're not going to be able to start again at that higher dose. They're going to really have to go either to the lowest dose, or some in clinical practice might go to the second dose. If they go straight away to the higher dose, they're probably going to have a lot of these GI symptoms. Now, if it's truly just a month, you would expect probably the weight regain is not going to be, it would be moderate. And that could be appropriate for certain situations and patients that have a lot of other risk factors that you're worried about. I think the concern with prolonged use is that, yes, there is weight regain with these agents. If someone doesn't tell the person when they're allowed to restart it and they end up off of it for a much longer period of time, we do worry about the regain. And one of the things I especially worry about, it's not just me, the literature supports this, is that when people gain the weight, they've lost muscle, and the weight that they regain tends to be a higher percentage of fat versus muscle. So it truly is a concern if somebody is regaining a bunch of this weight back and now they have less muscle, more fat. And so it is something we need to be aware of as well. But I think if you have a plan in place and you say, listen, this is just going to be for a month, and you talk about the potential weight gain and strategies to counteract that, then that's something that could work.
Excellent. And then there's one here, Diana from Jackie Phillips. I guess a lot of us are in this situation. So what should we do as a phase 1, phase 2 nurse to ensure patient safety? So we've not been involved in that whole stopping, starting, but what are we going to do in the PACU or the phase 2?
Well, so I'm less familiar with the roles of phase. I'll be totally honest with the phase 1 and the phase 2. I think whatever you can do to be ready, if you have contact with a patient and can get a good history about their medication taking, and if they've taken a GLP-1 drug recently or other drugs that could increase their risk, and just be on hand that there could be higher rate of, potentially having aspiration, having these emergency events, and kind of being ready with whatever equipment you need, whatever resources that you need, knowing that there can be this heightened risk of this happening.
Gotcha. Fantastic questions, guys. Okay, so another one here. In emergency situations, are there any medications being investigated to increase stomach motility?
Oh, there are actually. That is another strategy that can be used. So that was something that was mentioned in some of the articles, that yes, you can increase motility. You can try to clear out the gastric contents if they're there. So those are strategies that you could try to do in those situations. If you do that gastric ultrasound and you see that there's residual gastric contents, that could absolutely be something that could be done as
Excellent. Sorry, just looking if there's any burning questions we can try and do now. And
Someone
then,
was asking about the sleep apnea. So it's funny because we don't actually know. We suspect that the sleep apnea improvement is probably related to the weight loss. but it is possible there could be other mechanisms that directly improve the sleep apnea. All I can say is now there's a lot of people that have obesity and sleep apnea. We've never seen so many people jumping to get a sleep apnea diagnosis. And so it's just further kind of increased the use of these drugs.
Excellent.
Are patients destined to be on these drugs forever? The answer is we don't know yet. They are meant to be chronic medications. We're certainly not telling people to go off of them, but there is a lot of interest in seeing, can we decrease these? Can we safely stop them, or kind of decrease the frequency instead of once a week, like once every other week or every 3 weeks, to maintain the weight loss? So a lot of people are looking into it, but unfortunately, when people abruptly stop, most likely they do gain weight.
Excellent. Well, Diana, I think we've got probably 2-3 minutes left. Any other burning ones that you can see?
Do compounded GLP-1 share the same risk? I would argue they carry more risk because we don't know what people are doing or what dose they're taking, and you also have all kinds of things that are happening. People are microdosing. They're, instead of taking a weekly agent once a week, they're taking a weekly agent a few times a week. So it's kind of like the wild, wild west out there, and we don't. It's a concern, but the manufacturers of semaglutide and tirzepatide have created kind of these lower cost formulations. Are still kind of expensive, but the idea is to discourage people from using as many compounded versions anymore.
Excellent. Well, Diana, I think we'll go ahead and wrap it up. Just wanted to let everyone know, as long as that is in the next slide, that Diana has actually supplied her email address and very kindly given that to us. I'm sure that, well, I hope that Diana would be happy to answer any burning questions that we haven't quite seen in that chat there.
Definitely. And I also, you can find me on social media. I've listed my handle there at Diana M. Isaacs. Also, I do a podcast. It's called Diabetes Dialogue. I do it with this nurse practitioner, Natalie Bellini. And we talk about all different kinds of topics, diabetes, obesity related, kind of what's new and exciting in the space. So if you're a podcast listener, I guess you can find it wherever you listen to your podcast, but there's also video versions of the link provided as well.